Good morning. Welcome to CMC Ludhiana Grand Rounds. I'm Dr. Ashish Varghese, Vice Principal, Postgraduate Studies. I request Dr. William Bhatti, our Director, and Dr. Jairaj Pandian to please welcome Pratik before I introduce him. Dr. Jairaj and Dr. William, please. Dr. William.
Yeah, thank you, Dr. Ashish. Dr. Pratik, on behalf of CMC Ludhiana, we welcome you for today's Grand Rounds. And today's topic is very relevant to 21st century challenge, survivorship of after acute and critical illness. We do come across a lot of patients, those who have survived, and particularly following COVID and other illnesses as well. And I'm sure today's talk will answer our queries we do have. And we will come across the challenges faced by patients and healthcare institutions. Thank you for joining us for today's Grand Rounds. Thank you.
Good morning. On behalf of the Christian Medical College, Ludhiana, I welcome Dr. Pratik Pandey for this Grand Rounds. We thank you for accepting our invitation, and the topic that you have selected is so important, particularly during the time of this pandemic, and where we have felt the need of critical care. It was so crucial for every hospital where there was a need to upgrade the critical care services. Many people have survived, and not only the COVID-related illness, but also due to other illnesses because of the advances in the critical care. And but however, there are many consequences, short-term and long-term consequences that can occur as part of the management in the critical care unit, and we are looking forward for your talk. Thank you.
Thank you, Dr. William, Dr. Jairaj, for that. Welcome. Survivors of critical illness from medical and surgical ICU often have a prolonged and disabling form of cognitive and functional impairment. Can we avoid it? A landmark paper published in the New England Journal of Medicine talked about it. And today we have the principal investigator and the lead author, the first author of this paper from the New England Journal of Medicine, Dr. Professor Pratik Pandey. He is a professor at the Vanderbilt University of Medical Center at Nashville, Tennessee. He's got the James Taylor Gathme Professor of Anesthesiology and Surgery. He is Vice Chairman of the Faculty Affairs, Co-Director of Critical Illness, Brain Dysfunction and Survivorship Center. Pratik did his graduation from the Nagpur University, followed by residency in anesthesiology at St. Barnabas Medical Center, New Jersey. He completed his fellowship in critical care in 2001 from the Vanderbilt University Medical Center, Nashville. He is currently the professor of anesthesiology, surgery at the Vanderbilt University Medical Center. Among the numerous awards and honors that he's got, he was awarded the James Taylor Gathme Endowed Directorship in Anesthesiology in the beginning of this year. Pratik has got various grants and funding to the tune of $44 million. He has over 120 research articles, 12 editorials, and he's contributed for the evidence-based guidelines. His papers are mainly published in the New England Journal of Medicine, Lancet, JAMA, Intensive Care Medicine, American Journal of Respiratory and Critical Care Medicine. He is a visiting professor to 15 universities, which are the Cleveland University Hospital, Mass General Hospital, Harvard, Yale Medical School, Duke University, Johns Hopkins, to name a few. He has organized many workshops, presented his work at the local, regional, and international level. He has presented many external and internal grand rounds. He is part of many professional organizations related to anesthesiology and critical care. Survivorship after acute and critical illness. Dr. Pratik, the Zoom platform is yours for the grand rounds. Welcome.
Good morning, and thank you for this kind invitation. Thank you to Principal Dr. Jairaj Pandyan, Dr. Bhatti, the Grand Rounds Committee, and my dear friend Ashish Varghese, who we spent many years in medical school at Sevagram together for this invitation as well as the kind introduction. So today, what I'd really like to talk to you about is survivorship after acute and critical illness. Really, what we need to discuss is that as patients recover from specific illness that brings them to the hospital, whether it's a surgical process, whether it's COVID, in the present pandemic, etc., we need to understand what happens to the trajectory of these patients' lives after they leave the hospital, and whether they have cognitive impairment, functional impairments, mental illnesses, etc., which prevent them from coming back to the same quality of life that they enjoyed previous to their critical illness, and whether there are strategies that we can employ to try and mitigate these circumstances and improve the lives of the patients. As a disclosure, I do need to let you all know that I have research grants from Hospira, now taken over by Pfizer, which makes dexmedetomidine. It's an alpha-2 agonist, which one uses for sedation in the ICU. These grants were in collaboration with the National Institutes of Health. I do have salary support from a number of NIH grants, as Dr. Varghese has pointed out. Now I'm going to put this into context using some US data. The numbers in India obviously are much higher, but annually about 6 to 8 million patients arrive into the intensive care unit in the US. And about 4 million patients survive the critical illness. So that's really great that a number of patients who come to our critical ill areas make recovery and leave our ICUs alive. The question is, what is the quality of life that these patients have after they leave the ICU or the hospital? Now, if you look at temporal trends in mortality, over the last 20 years, we have made significant improvements in the care of our patients, whether they are critically ill with sepsis or critically ill without sepsis. And this study that was published in JAMA shows that if you were admitted in an ICU in 2000, as compared to 2012, your probability of survival in 2012 is significantly higher than your probability of survival in 2000. So that's great. Our patients are getting good care in the hospital setting, and they are surviving a critical illness or a major hospitalization. The question is, at what price does this occur? The same study looked at where do these patients who survive actually end up. Are these patients surviving the critical illness and the hospitalization and going home? Or are they going to other facilities such as skilled nursing homes, long-term care units, etc.? And what this study showed was that while it is true that many patients survived later on, as in if you look at data in 2012, more survivors in 2012 as compared to 2000, but a much higher proportion of patients go to a place other than home. So much higher odds of going to a place other than home if you survive in 2012 as compared to 2001. The question is, what have we done with regards to improving survival? And so if you look at this big picture of survival after an acute illness, if our current paradigm is that a proportion of our patients have full recovery, some patients have significant morbidity, and some patients die. Now, if we improve care such that we reduce death, the question is, does that come at the expense of significant morbidity? So what we've done is we've basically changed the viability threshold. Instead of patients dying, they now survive, but with significant morbidity. We have not made any difference as far as full recovery goes, with both these graphs being exactly the same. Or is there a trade-off that you improve death, you reduce death, but it comes at the expense of full recovery, and the proportion of patients with significant morbidity is the group that actually increases. On the other hand, I think all of us who take care of patients would prefer that we have a significant proportion of our patients having full recovery only a small proportion might have significant morbidity, and that we reduce death. So hopefully one understands that our goal when we take care of patients is to increase the full recovery, reduce the significant morbidity, and obviously try and improve mortality or reduce death. So I think the big challenge for all of us in the 21st century for acute and critical care is survivorship. We are doing well with making sure that patients survive a critical illness. The question is, can we get them back to their family, to their hobbies, and get them back to work? Can they go back into society and become significant contributors to society as they were prior to their critical illness? And that is something that I think our patients want. They do not just want to survive, they want to survive and be able to get back to the same quality of life that they were enjoying prior to some acute illness or hospitalization, which took them on a downward trajectory. If you look at specific patient populations and look at data from those patient populations, such as survivors after sepsis or survivors after ARDS, about 30 to 50% of patients are cognitively impaired months to years after they have survived a critical illness or in hospitalization with ARDS or sepsis. A number of patients are functionally impaired. About 60 to 80% of our patients who have a long-term hospitalization, and this was in Lancet Neurology, showing that they would be functionally impaired months to years. Now, it's possible that the proportion of patients who are disabled because of the impairment would be lesser, but a number of them have functional impairments preventing them from enjoying certain quality of life that they may have wanted to prior to their illness. An area that gets relatively ignored is that survivors of an acute illness and critical illness also have poor mental health. Depression is seen commonly in survivors of critical illness, and an area that is being now a focus is post-traumatic stress disorder after a critical illness. And I'll talk about that in the next few slides in a few minutes. Now, while there were data which clearly articulated that patients who survived after ARDS or after sepsis had cognitive impairment, a question that was unanswered was, do patients who come to our ICUs with respiratory failure, with shock, are relative bread and butter ICU cases? What are the long-term trajectories of these patients with regards to cognitive impairment, as well as functional impairments and mental illness? So this is one of the largest studies that has prospectively looked at cognitive impairment after critical illness. And this is the study that Ashish referred to in his kind introduction. This was published in the New England Journal in 2013, so it's already 7 years since it's got published. Prior to this study, the largest cohort looking at critical illness after or cognitive impairment after critical illness had been in the 50 to 70 patient range. This study, we enrolled 821 patients who were admitted to a medical or a surgical ICU with respiratory failure or shock. About 90% of the patients were mechanically ventilated, but about 10% were not. They were requiring either high flow nasal cannula, non-invasive mechanical ventilation, etc. Because this was a prospective study, we got detailed in-hospital course with regards to lab work, with regards to blood draws, as well as did long-term follow-up for these patients for cognitive impairment, depression, and functional status. Now, the results of this study have been published for the 1-year follow-up. We have been following this cohort for a long period of time. We have 4, 6, and 10-year data that is now being accumulated and hopefully published relatively soon. Now, for this study, we used a test called the R-bands to assess for global cognition. And the R-bands is adjusted for education and for age. And for normal adults, the score for the R-bands is 100 with a plus or minus 15 standard deviation around the mean. And that's shown in the green dotted line over here. The R-bands is validated for other patient populations such that we know that patients with mild cognitive impairment have scores of about 90. Those with moderate traumatic brain injury have scores shown in this purple dotted line of about 77. And those with mild Alzheimer's disease had scores in the 67 range or so. Now, when we assess these patients who, using surrogate questionnaires, had no prior cognitive impairment, and we assessed these patients at 3 and 12 months, what we found was dramatic reductions in their scores with regards to the R bands. So I'm going to focus in the less than 65 years of age. So this graph that you see is less than 65, greater than 65. We'll break this down and look at just the less than 65, because this is the patient population that is still contributory to society with regards to earning and making sure that they're supporting their families, etc. And we'll look at just the 12-month follow-up. So the median score at 12 months for this patient population was 80, which is 1.5 standard deviations below the population norm. When you look at scores in the range of traumatic brain injury, about 33% of our patients who had no prior cognitive impairment had scores in the range of what would be seen a year after a patient perhaps had had a traumatic brain injury. What was even scarier is that about 20% of our patients had scores in the range of what would be seen in mild Alzheimer's disease. So imagine patients who had no prior cognitive impairment, having an acute illness which required an hospitalization and an ICU stay, and then assessed a year later, having scores in the range, about 20% of those patients, in the range of what would be seen in patients with mild Alzheimer's disease. Now, as I said, this was the less than 65 years of age population. The median age in this entire cohort was 55 years. So it was not a population that we were studying, a geriatric population. It was a population of adults who are contributory members of society with significant decreases in their global cognition score. Now, one might say, well, does it change depending on whether it is an elective or a non-elective hospitalization? And this has been answered in a study that was published in Neurology in 2019, a rather elegant study, 777 patients in the Chicago Rush Memory and Aging Project. This is a large project based on the Alzheimer's Center, and they had taken patients who were 65 years of age without prior dementia, and they followed these patients for over 10 years. And they would test these patients every year for their cognitive assessment for working memory, semantic memory, visuospatial abilities, etc. And then in these patients who were being followed, they also tried to figure out whether they had any emergency hospitalization or an elective hospitalization, and then controlled for a number of baseline and numerous covariates. And what they found was that if you look at the graph on the left, for a period of time, the patients who are not hospitalized, you can see in black. Those that are hospitalized is shown in blue. And the pre-hospitalization, the cognitive trajectory was about the same, that there was a decline over time, which is decline in cognition with age over time. But what happens is, if you are hospitalized as compared to those that were not hospitalized. So hospitalized shown in red, not hospitalized shown in black. You can see that while the graph decreases and the slope decreases in the group that was not hospitalized, the slope decreases even more significantly in the group that had hospitalization. So an interval hospitalization resulted in a change in the slope of decline in cognition as compared to the slope if you were not hospitalized and had decline in cognition based on just age and time. Now, if the same graph is broken up into whether it was elective versus an emergency operation or hospitalization, you see this on the right-hand side. If you were in for an elective surgery or an elective hospitalization following a surgery, for example, your decline in cognition over time mimics that of a non-hospitalized patient. However, if it was an emergency admission, that's where that slope really declines. The take-home message over here is that an interval hospitalization or an acute or critical illness changes the trajectory of cognitive decline. Now, there are a number of factors that might be contributory to this, and we will delve into this in the next few slides. But it's important to realize that something that brings a patient in to the hospital in an emergency, and then things that happen to the patient, some of it may be part of medical care that we unknowingly are contributing to this decline, then results in a trajectory of this patient's cognitive decline much worse than if this was an elective hospitalization or no hospitalization. Now, switching gears a little bit to disability outcomes, again, from that Brain ICU New England Journal paper that I shared a little while ago, when we looked at ADL disabilities, so that is disabilities in the activities of daily living, and I'll show you what those are in the next slide. What we found was that about 1/3 of our patients, even at 12 months, were having an activity of daily living disability. That means even though 60 to 80% of the patients have some functional impairment, majority of them have the ability or reserve to be able to overcome those functional impairments, and it does not lead to a disability. But in 1/3 of the patients, those functional impairments actually results in a disability. If you had prior disability, you had a much higher probability of disability at 12 months. This goes to talk about frail patients who then have a critical illness. Their decline with regards to functional impairment and disability is much steeper than those who have not had prior frailty or disability. Now, the instrumental activities of daily living are a step up beyond activities of daily living and bring into account some of the cognitive status. And again, you see about 20 to 25% of patients having problems with their IADLs. Now, what are basic ADLs and what are instrumental ADLs, just so that we are all clear on this? Basic ADLs are being able to bathe and shower, to dress, to eat, to be able to move around in the house, to go to the bathroom, to have a bath, etc. So think about these basic activities. And if you look at our ICU survivors, about 30% of those patients were not able to do at least one of these basic activities of daily living. Now, 25% could not even do some of these instrumental activities of daily living. And this is the higher order activities of daily living, which add a cognition piece into it. So doing housework, taking medications. Imagine a sick patient who has a number of medications and then cannot think about the right way to take these medications. Managing money, financial abilities is a big issue right now with a lot of fraud that goes on with the internet now. Managing money is a big problem that some of our senior survivors after critical illness are having taken advantage of. Being able to do shopping, groceries, etc. Important activities of instrumental activities of daily living, which are impacted in our patients who are surviving a critical illness. Now, we talked about the R-band score and the decline in the R-band score in the patients who have survived a critical illness. And I shared with you all that about 30% of patients had a decline in R-band score in the range of patients with moderate traumatic brain injury. And about 20% of them had scores in the range of patients with a mild Alzheimer's disease. Now, one might say, well, you're saying that these scores decrease, but does it really impact a patient's ability to do anything? These are data from the same study. And in this study, we knew that about 90% of our patients pre-illness were fully employed. However, when you look at 1 year employment, only about 43% of patients are able to go back to that full-time employment. And part of the reason why they are unable to go back to their same job is the loss of cognitive abilities or the loss of functional abilities, which prevents them from going back to jobs which may have physical labor as part of the job. So significant impact, not just on scores, but actual practical value where patients are not able to go back to work and be contributory members for their families, as well as for themselves and for society. Now, the third aspect, we talked about cognitive aspects, we talked about functional impairments, talking about mental health outcomes. About 30% of patients who survive a critical illness have some form of depression. Most of the time that we see this depression, it's the somatic type of depression where patients have more lethargy, problems sleeping, etc. And that's an area which prevents them from, again, going back into the same quality of life and back to work, back to enjoying social interactions, etc. Something that one needs to be aware of when you're taking care of these patients who may not be able to go back to doing things that they wanted to do because of the mental illness and depression. Now, an area that is relatively ignored is PTSD. We are all aware of PTSD that occurs after patients who are involved in a traumatic event, whether it is abuse, traffic accidents, etc. And patients have PTSD, or civilians have PTSD regarding that. There is PTSD seen in combat veterans, so people who come back from war having PTSD. And these symptoms are where they've actually had an exposure to a life-threatening event, and then they have intrusion memories where they keep having memories of that event. They want to try and avoid any activities that reminds them of that trauma, or they have significant hyperarousal, etc. So these symptoms that are seen normally after either a life-threatening accident or combat situation, etc., is also being reported in patients who have survived a critical illness and the memories that come with that critical illness. So being on the ventilator, being tied down with restraints, having memories or delusions while being on the ventilator under sedation, which then results in some long-term ramifications with PTSD. Now, our group looked at the incidence and risk factors of intensive care PTSD after assessing whether these patients had any history of prior PTSD, whether it was because they were involved in a combat or they had any prior life events which were traumatic. And what we found was that when we anchored the PTSD assessments on the ICU stay, about 5 to 10% of patients reported PTSD, full-blown PTSD regarding their ICU stay. Now, one might say, well, 5 to 10% is really a small number, but in the general civilian population, rates of PTSD are about 2%. And if you look at combat veterans who come back from active war, rates of PTSD are about 10%. So our ICU survivors have PTSD in the same range as those patients or those people who come back from war. So it's pretty high. What is even more alarming is that certain symptoms of PTSD are even higher than the full-blown PTSD. So intrusion, for example, was seen in about 15% of patients at 3 and 12 months follow-up. Avoidance was seen in about 40% of our patients. And avoidance is, for example, that they avoid any circumstances which remind them of that ICU stay. In our case, what we found was our survivors would not come back to our hospital because they did not want to have any memories. So follow-up visits, etc., coming back to clinic was a major problem in many of our survivors after critical illness. And then hyperarousal or being sort of very jittery was another area that was seen in about half of our patient population. So PTSD is something that does occur in a proportion of patients who survive a critical illness. And as healthcare providers, who take care of these patients, one needs to be aware that our patients may have PTSD along with other symptoms such as depression, cognitive impairment, and the functional impairments we talked about. Now, while it is true that our patients may have certain elements of what's called post-intensive care syndrome, the psychological sequelae, the quality of life decline, etc., one also has to realize that family members also take a big hit when they have a loved one in the hospital. And this is an area that is being worked on, the family post-intensive care syndrome. Are there psychological sequelae and decrease in quality of life of even family members who have a loved one in the hospital? Are our family members getting depressed, seeing their loved one in the hospital undergoing a rough course? And that's something that we do need to be aware of, that our family members may also be having problems as a sequelae of their loved one being in the hospital. Now, these impairments that are seen in our patients, whether it's cognitive impairment, physical impairments or functional impairments, and mental illness, don't happen in isolation. Often, some patients have 1, 2, or all 3 of these impairments, and that obviously results in much worse outcomes. A proportion of our patients, and this is a study we looked at, what proportion of our patients are PICS-free or post-intensive care syndrome free, and about 35 to 36% of our patients had no symptoms of cognitive impairment, functional impairment, and mental health. And really, that's a group that we want to learn from. Why is it that a number of our patients have a critical illness, but some patients survive without any long-term sequelae? And really learning from that group would be helpful. And we'll talk about that in the next few slides. So when you look at the risk factors for cognitive impairment and functional impairment, there are certain baseline vulnerabilities that one needs to be aware of. And some of this seems common sense, right? Older patients might have a higher risk of cognitive impairment as well as functional impairments. Education has been shown to be a big risk factor in the sense that lower education is associated with worse cognitive impairment. And that has been seen in other neurological diseases as well. When you look at traumatic brain injury and you look at sort of total amount of blood in brain, those who have a higher level of education seem to have less sequelae from that traumatic brain injury than those who have a lower level of education. Similarly, in some of the data coming out from Alzheimer's disease, looking at plaque burden, those with a higher level of education, even if you have the same amount of plaque burden as someone with a lower level of education, those with a higher level of education seem to have less sequelae from that plaque burden when patients were alive, when you've then assessed them later on with autopsy results. Prior impairment obviously puts you at a higher risk factor. And then frailty is another area that if you have baseline frailty, that's a baseline vulnerability, which will put you at a higher risk of developing cognitive impairment as well as functional impairments months to years later. With regards to the hospitalization, we mentioned that when you are hospitalized, your trajectory of cognitive impairment and functional decline rapidly changes. What is it within that hospitalization that puts you at risk? Some of the work that's been done is looking at whether sepsis is a major risk factor. When you are septic and then you get delirious, does that change your trajectory and does it make it even worse? And are surgery and the anesthetics that go along with it, are those implicated in the post-operative cognitive impairment that people talk about, or the cognitive impairment that is seen after critical illness? Now, when you look at socioeconomic status and education, one of the frameworks that has been discussed is that if you have a higher level of socioeconomic status or higher level of education, then you have a reserve capacity. And this reserve capacity is reserve capacity with regards to social support, reserve capacity with regards to finances, etc. And so therefore, then when you are stressed, but you have the reserve capacity, your negative emotions to that stress are lower. So if, on the other hand, you had a lower socioeconomic status, you were less educated, you have less reserve capacity. So therefore, when you are in a stressful situation, you have a significantly higher negative emotion because you do not have the ability to fight what is happening to you, not just the illness, but the social construct around you. And when you have negative emotions, the resilience that you have may be decreased. So some of this framework talks about resilience, and that social economic status and education provides you with that reserve capacity to have higher resilience to stress, and therefore you tend to have better outcomes than patients who have a lower socioeconomic status or lower education. A study that looked at acute care and critical illness and hospitalization and change in trajectory was this large study done by Bill Ellenbach. And this was done in Seattle as part of a health cooperative. And what they did was they took about 2,800 patients, and they just followed these patients yearly with a cognitive test called the CASI. And these patients were just evaluated. They were less than 65 years of age and they had no prior dementia. And of the patients that were being followed, some patients had hospitalization and some patients had a critical illness. And let's just look at the hospitalization and the no hospitalization. So of the group, 1,600 patients of the 2,800 odd patients, 1,600 patients had no hospitalization, 1,200 patients had hospitalization. Of the 1,600 patients who had no hospitalization, over the course of the study, 146 patients had a case of incident dementia versus 228, so a higher proportion of patients having incident dementia if you had one or more non-critical hospitalization. And then in the multivariable regression, if you did no hospitalization as your reference, if you had an interval non-critical hospitalization, your hazard of having new or incident dementia was 50% higher. So something that brings patients into the hospital and things that happen in the hospital changes your trajectory such that you have a 50% higher hazard of developing dementia in the ensuing years as compared to the group that had no hospitalization. Now, digging deeper into what within that hospitalization may be associated with the risk of developing cognitive impairment. This was a study done by Jackie Vashina, again published in JAMA. So these are all papers published in high impact factor journals. And what this group did was they again looked at a group within a health consortium and assessed these patients regularly for cognitive impairment and looked at the patients that had sepsis and those that did not have sepsis. And they looked at patients' scores prior to sepsis and then after sepsis. So if you look at the last survey before sepsis, so 1 year before the septic episode, the cohort had mild cognitive impairment in about 7% of patients and moderate to severe cognitive impairment in about 5% of patients. Now, a year after the septic episode, when patients were assessed for cognitive impairment, proportion of patients with moderate to severe cognitive impairment was significantly higher, 5% here versus 15% in the year following sepsis. And in the multivariable regression, sepsis was associated with a 3 times higher odds of developing moderate to severe cognitive impairment. So just building the story further, hospitalization leads to a higher trajectory of developing cognitive impairment. Perhaps sepsis within that hospitalization adds to that, and that may be one of the inciting reasons why patients developing cognitive impairment. And then our group looked specifically at delirium. And what we found was that if you looked at that R-band score, which we talked about for the brain ICU study, and on average, the score was 80. But if you add days of delirium, the greater the days of delirium as shown on the axis over here on the x-axis, by the time you got 5 days of delirium, that median score decreased further by at least half a standard deviation. So just thinking about the things that might be risk factors for developing cognitive impairment, hospitalization, the things that bring you there, sepsis, and that delirium within that hospitalization adds to this growing risk factors for developing cognitive impairment months to years later. This has been looked at even in post-operative cases. So think of your surgical patients either having cardiac surgery or non-cardiac surgery. And in this study, again published in the New England Journal, what they found was that patients who underwent cardiac surgery, they were assessed with the MMSE or the mini mental state exam, and that's shown on the y-axis. And over time, scores decreased. So in the first 2 or 3 days after surgery, everyone's scores decreased. But if you had no delirium, your scores came back to normal. On the other hand, if you had less than 3 days of delirium, you had a big decline in your MMSE right up front, but relatively soon you started coming back. On the other hand, if you had greater than 3 days of delirium, Your scores on the MMSE decreased significantly, but it took almost 6 months for them to come back to baseline. This study was repeated in non-cardiac surgical patients and showing a very similar trajectory that the greater the days of delirium in the postoperative period, the longer the recovery of cognitive status postoperatively. So something to think about as we take care of patients either in the ICU or even in the postoperative wards, as far as delirium and the risk of cognitive impairment ensuing after that. Now, this is really even more important in the pandemic time that we are all undergoing, and because there have been a complete change in the paradigm of how we are caring for patients, both because of the severity of illness, as well as shortages of beds, shortages of drugs, etc. Now, we wanted to look at delirium and coma within a cohort of patients with COVID. And so this was the COVID-D international cohort study, which was published a couple of months ago in the Lancet Respiratory Medicine. And what we did was we had a collaboration of over 2,000 adult patients that we enrolled from 69 sites over a number of countries. We did prospective delirium and coma assessments over the period of time when they were in the hospital. We got detailed information about their hospital stay, and that tried to look at the risk factors that were associated with delirium to try and see whether there's something that we can do to mitigate the potential cognitive impairment and functional impairments that we may see in the survivors of COVID. So one of the concerns is that we will recover from the pandemic and we may have an epidemic of cognitive impairment, functional impairment, and mental illness in our survivors after COVID. Now, what we found in this patient population of over 2,000 patients is that the median age was 64, our SAPS score was 40, so mild to moderate at the first admission, because many of these patients, when they first came in, were on nasal cannula or on non-invasive, and then gradually progressed towards invasive mechanical ventilation, which was seen in 88% of patients. What was terrifying is that coma occurred in 81% of our patients for a median of 10 days, and patients were delirious for a median of 3 days. So a significant proportion of patients spent almost 2 weeks with some form of acute brain dysfunction, delirium or coma. And when we looked at risk factors, what was seen was there was a change in paradigm of sedation away from what is now the present guidelines of trying to use non-benzodiazepines for continuous sedation in ICUs, back to using benzodiazepines. So in this cohort, 64% of patients got benzodiazepines for an average of 7 days. Propofol was used again for 7 days. So significant proportion of patients were getting long-term sedation for a long period of time and high doses. Family visitation, as has been seen by many in the pandemic, was reduced. And when we looked at risk factors for delirium, the two strongest risk factors for delirium in this patient population was the benzodiazepine use, as well as the lack of family visitation. Looking at whether surgery is a risk factor for cognitive impairment and the anesthetic exposure, in the brain ICU cohort, when we broke this up into cognitive impairment in surgical patients and non-surgical patients, you see that the scores are about the same. A number of studies have looked at the contribution of surgery and has found that surgery and anesthetic per se may not be risk factors for delirium or the long-term cognitive impairment, but it is the patient characteristics coming in and some of the things that we do to these patients during their critical illness that might contribute greater to the cognitive impairment. In the last few minutes, I just want to talk about how we could, as healthcare providers, try and improve survivorship and tackling some of the modifiable risk factors. Now, we cannot change the educational status of our patients. Where the patients come with prior cognitive impairment, we cannot change. But there may be risk factors such as sepsis, sedation and delirium, immobility, and frailty that we may be able to tackle in our patient population. Now, one thing to keep in mind is that there are a number of supportive measures that in the past one would consider as the back end of critical illness. So when you have a patient who's critically ill and you're resuscitating them, etc., often a lot of attention is not paid to hypoglycemia management. And we were talking to Dr. Varghese a little while ago that even in the COVID pandemic, care with regards to steroids and oxygen was being provided, but perhaps hypoglycemia was not being taken care of. And that has resulted in a fair amount of fungal infections later on. So that's something to keep in mind, that hypoglycemia, fluid management, the restrictive transfusion practices, nutrition, antibiotic stewardship, all these things which often are done at the back end need to be moved right up front. And we really need to pay significant attention to those to try and reduce the sequelae of sepsis and therefore then the long-term effects that might happen after that. An area that we have been focusing on is on improving analgesia and sedation, delirium monitoring, getting people mobilized, and improving sleep. And the Society of Critical Care Medicine has provided some guidelines with the A2F bundle. So the A2F bundle is a framework which uses some of the guiding principles of the pain, agitation, delirium, immobility, and sleep guidelines, which the Society of Critical Care Medicine has published. And what the focus is on is to assess and manage pain. So really taking care of patients' pain and try and prevent giving too much sedation, doing both awakening trials and breathing trials. So every single day, trying to assess your patients who are in the ICU to see whether you can wake them up and you can give them spontaneous breathing trials. And this has shown to reduce time on mechanical ventilation and reduce sedation exposure. Choice of sedation, or C, is trying to avoid continuous sedation whenever possible and avoiding benzodiazepines if possible. Again, in the pandemic, one has reverted to using benzos, but as we have learned from the second and third wave, trying to avoid that is really associated with better outcomes. Assessing patients for delirium and using strategies to try and mitigate delirium, mobilizing patients and getting them mobile, especially our frail patients, might improve outcomes in those patients. And then family engagement, getting our families engaged to try and get them part of the care team to try and improve the outcomes. Couple of studies that are going on right now, which are showing some promise. Early physical therapy in the ICU has shown to get people off the ventilator faster, reduce their delirium, and so that is an area of focus. The return study is a study that we did, which did physical and cognitive impairment after patients survived to try and get them back to their same quality of life. The ACT ICU study is a study that is looking at starting physical and cognitive therapy, both, even the cognitive therapy when patients are in the ICU. And then the prehab study is a study that we've just started, is trying to get patients who are coming in for large surgeries, especially cancer surgeries, to try and do physical and cognitive prehabilitation for 2 to 3 weeks prior to them either getting chemotherapy or 2 to 3 weeks prior to them getting resections for their surgical, for their cancer, etc., and try and get them optimized up for that. And these studies have all shown some improvement in outcomes. In the interest of time, I'm not going to share those. Something just keep in mind that rehabilitation may be an area that one needs to focus on. This is just some of the guidelines that we have. We have a booklet. We are doing elastic bands, resistance training, as well as then using computerized techniques to try and do brain exercises in our patients prior to surgery to prepare them for the stress that might occur. So I'm going to end by reminding everyone that we have done a tremendous job in improving survival after critical illness and acute illness. But really where we need to now focus is on survivorship. And that really is our challenge. We need to get our patients back. And the pandemic is a big reminder to back to their families, back to their hobbies, back to their work, back to their social interactions, such that they're contributory members of society. With that, I'm going to end. I have a large team that is supporting the work we do over here. And it's because of them that we've been able to at least succeed in trying to provide data for healthcare providers about what some of these long-term ramifications are in our patients. Thank you.
Thank you, Pratik, for that excellent presentation. it's open for questions. You can unmute yourself and ask Dr. Pratik questions directly. And there is a question in the chat box. Dr. Pamela Jairaj, she is a radiation oncologist. She wants to ask a question. Have you used distress thermometer in this group of patients, that is cancer survivors? How often do you have family meetings in long-term ICU admissions?
So with regards to your first question, first of all, thank you so much for that question. Very good question. We unfortunately have not used distress thermometers, and this is something that I'm probably going to have to read up a little bit more about and try and utilize that. We do use psychologists in many of our family meetings, especially with patients who are undergoing sort of long-term therapies. With regards to the family meetings with long ICU admissions, we'll talk about non-COVID times and then COVID times. So in the non-COVID times, families are at the bedside 24/7. So we have open visitation where families can stay, 2 members of a family can stay with a patient throughout the day, and 1 patient can stay overnight. During rounds, when we do critical care rounds, the families all are part of critical care rounds. So we have discussions with families every single day. And then on top of it, then there will be additional family meetings at least once a week to assess goals of care. So while daily updates are happening, there are sort of critical branch points that are occurring. Do we go dialysis route? Do we not go dialysis route? How, what would the patient want in that circumstance? Those happen in a multidisciplinary manner about once a week, I would say.
Thank you, Dr. Pratik. I think it was great. It is new to me to hear that the family members also come for the critical care rounds in the ICU. So that solves everything about the family meeting. So they are in your discussions when you take the decisions, the shared decisions.
Right. And, we've started this probably 4 or 5 years ago. And, there was always trepidation that having family members and they hear everything. Sometimes they're hearing about mistakes that our trainees have done overnight, but that's all discussed in an open forum. And it actually has been very good of saying, we did a central line, we got a pneumothorax, we've had to do this, and it's discussed right in front. So there is a fair amount of trust that gets built up because we share the good, but sometimes we share the bad. There was an error in medication. There was an IV that infiltrated and we were using vasopressors that were running through an infiltrated IV. We have the same problems that everybody else has, but I think acknowledging it during those family rounds really helps.
Thank you so much for that comprehensive talk. And I should say that though you spoke about acute and critical care illness, the survivorship, we are at the other spectrum, like with cancer patients and, cancer-directed therapies and the survivors, what all they face. But it's similar, and I think a lot more problems we have to handle.
But I think it's important, one of the things that we talk about is that even for cancer patients who may not have many more months to live, survivorship for those few months is also important. So being able to be part of whatever they want to achieve in the 1 month that they have to live is an area that we have to care, and that is also survivorship.
Yes, yeah. Thank you.
Sure.
Yeah,
Dr. Samir is with me, our intensivist who has recently joined us. He wants to ask a question.
Pratik, Dr. Samir is a new ICU consultant, a critical care consultant.
Hi, sir. Good morning. It was rather good evening there. It was a wonderful lecture. Just wanted to know, is there really something being done on melatonin, and has melatonin actually proved its role when we were talking about this, like post-intensive care syndrome?
So there's been some work done with melatonin, specifically Rameltion and Delirium. One study with amazing results, which often I'm very skeptical about. All follow-up studies have shown no benefit. So while there is ongoing work on it, I don't think we know the answer yet. And at this point, I would say that In certain patients, melatonin helps with improving sleep, but the long-term ramifications and improvements, I don't think we can say that it is a proven therapy at all.
Is it same for both the hypoactive as well as hyperactive?
I do not use treatment for hypoactive at all. I try and de-prescribe as much as possible in the hypoactive delirious state. And even in the hyperactive delirious state, I only try and use either melatonin or antipsychotic medications for the acute agitation if it is considered dangerous for the patient. Most of the time, it is trying to find out the underlying sort of risk factor and trying to reverse those kind of things. And it's those areas that I'd focus. So unfortunately, we don't have any magical drug for delirium either. And I think one needs to realize that even when we use antipsychotic medications, all we are doing is we're doing symptomatic management of the agitation, often converting hyperactive delirium to hypoactive delirium, which at least makes all of our lives easier. As consultants, you don't get called for these patients, but not sure that we are actually doing any good for those patients by doing that.
So opioids are completely safe?
I would say opioids targeted towards pain management is probably the way to go. Overprescribing of opioids is also probably not safe. So on the other hand, pain is a risk factor for delirium. So that tight balance is something one has to achieve. And only if you assess patients regularly for pain, you'll be able to target those therapies for the pain and not use opiates for the additional side effect, perhaps, of sedation.
We should have a follow-up clinic, sir, you believe, like our post, because the rise in critical care patients all over the world has been exponential, actually. Should we really have a clinic post ICU care or something like that? Or is there something existing back in the US?
Yes, so we have a very robust post-ICU clinic at Vanderbilt. Unfortunately, only about 10 or 15 post-ICU clinics exist in the country. Part of it is because nobody funds those, and so therefore it becomes a problem, but it is very robust. And there are a number of questions. So, one of the things maybe you and Ashish can share my email, and I'll be happy to connect you with some of our post-ICU folks. I have two questions. I have a hand up for Vikas.
Yeah, Dr. Vikas Lumba. He's professor of medicine. Dr. Vikas, you can ask Pratik.
Dr. Pratik, it's a very nice presentation, very good overview. I wanted to know, when you're managing these patients, are you taking care of the caregiver stress also, or you're not about that? Because
so we the only way we are taking care of caregiver stress is apart from our post-ICU clinic where we're taking care of our patients. We also have support groups where we meet our patients and caregivers, and it's a mentor support group where older survivors of critical illness mentor younger survivors of critical illness to prepare them of the challenges that are going to occur in the next few months. And at this point, we also see the same thing happen with family members. So a wife of a patient who has been a survivor for a year, coaching a younger wife, younger in the sense, younger survivor wife, saying that, this might happen, be aware of this, don't think that these symptoms are just the patient being arrogant, it may be some of the cognitive impairment, it may be PTSD, etc. So that's how we are doing caregiver support, at least.
So something like Alcoholic Anonymous, we have something like Alcoholic Anonymous, where we have the people guiding the other people. That can be a good way that we can go about it.
Yes, and the support groups really are amazing. We have had very good success with our support groups and feedback from our patients saying that one is that at least, similar to, like you said, the Alcohol Anonymous, etc., nobody's judging those patients. They are all feeling supported. They know that others have also been through the same thing. So there's no judgment, and that makes it really a good supportive thing. And there have been groups that have then formed just one, helping each other even without us being involved in it. Dr. Vineet, I think you have a question.
Vinit is a neurologist. He would like to ask you, standardized cognitive assessment in India is challenging because of the multiple languages and varied education. Is there a progress in overcoming this barrier in assessing cognition?
Not as much as one should have. We have tried hard trying to get the Delirium tools at least translated into a number of languages. So, the CAM ICU, for example, is a delirium assessment tool. A brief ICU delirium assessment tool is now translated in at least 4 Indian languages. And we're trying to work more, again, even within India, there are so many languages and so many dialects that we are working on that and find collaborators. So again, if there are folks on this call who would like to be part of this, we would love to partner with you all because there are only certain languages that we have the skill set to try and do from here, but would love to partner with you all on that one.
Dr. Rajeshwar, he's again a neurologist. He wants to know, for patients on ventilator, besides Dexmed, what are the sedatives with least chances of developing delirium?
Yeah, so, the MENS2 study was a study that we just published in the New England Journal in February of this year. And that was a comparative study of dexmedetomidine and propofol. And what we found was that those 2 sedative agents appeared to be equal in their impact on delirium and other outcomes. So what I would say is that, your first option is, can you have a patient in your ICU on the ventilator who does not need sedation? And a number of patients would be that way. So we have patients on the ventilator who will be writing notes. We have patients on the ventilator who are now walking with our physical therapist. So we don't use sedation in all our patients. And in the patients that have ventilator patient dysynchrony or significant agitation and you have to use sedation, I would say propofol and dexmedetomidine are your 2 agents of choices after you have ensured that they are pain-free. So trying to use one of the tools such as either the CPOT or the behavioral pain scale, which are used for non-communicative or non-verbal patients for assessing pain. Once you take care of pain, then trying to use either propofol or dexmedetomidine at the lowest possible dose that you can use to try and get them comfortable would be the approach. I would avoid benzodiazepines as much as you can. And I know that there are a few neurologists over here. For your seizures, feel free to use your benzos. We now have even better agents even than Ativan for even seizure disorders. But I think those are the only few times that I actually use benzos. Have a patient with status epilepticus or breakthrough seizures. When I have someone in Keppra, we often will use a little bit of Ativan to try, or lorazepam to get control. But otherwise, our benzodiazepine use is less than 1% at Vanderbilt.
Yeah, thank you, Pratik, for answering all those questions. Dr. William and Dr. Jairaj, their final comments, and then we'll wind up the grand rounds. Hello, sir, you have to unmute. Dr. William, you have to unmute.
Thank you, Pratik, for excellent talk. We are really benefited. And as you know, we have gone through pandemic and we are facing challenges with many patients, those who had experience of ICU and hospitalization. And certainly your talk will benefit us how to manage these crises. Thank you.
Yeah, I think it's a fascinating talk. And there's always a parallel between predictors or risk factors for dementia versus risk factors for cognitive decline in people who undergo ICU care. There is a big potential for prevention. If we identify these factors early in the ICU or even before they occur, there is a big opportunity for prevention here. And so thank you very much. It has really enlightened us, not only from the critical care point of view, but also for us as who always deal with the brain and other other related issues. So thank you very much. Yeah.
Thank you. And for anyone who would like to collaborate and have ideas and want to participate in research projects together, our center would love to do these partnerships. So feel free to reach out to me, and we can have some good collaborations.
Thank you. One thing, Pratik, as a non-critical care consultant, I learned through this meeting is to bring the back end of critical care to the front end. You happy? A non-critical consultant learning this?
I'm delighted.
Okay, thank you, Pratik. Thank you for that excellent talk and getting everybody involved in the discussion. Next Saturday, we have Dr. Rashmi Cherian giving us a talk on secrets of nutrition and fitness in the COVID-19 era. Thank you, and we'll see you next week. Thank you, Pratik, again.
Bye.
Bye-bye.
Thank you. Thank you.
Good morning. Good morning. Good morning.